So our first speaker is Carvell Nguyen from Metro Health. He is a urologic surgeon, and he's going to talk about prostate cancer 2025.
Thank you, Mary. Morning, everyone. I'm honored and excited to be here with you all this morning, and as Mary just mentioned, she asked me to give an overview on, I guess, the state of the art in prostate cancer in 2025. It's a very broad topic. I hope that I will hit all the high points and show you some of the exciting things that are coming up in our fight to control and beat prostate cancer. So, as we know, prostate cancer is a significant health issue. It is one of the leading causes of cancer and cancer death in men, not just in the United States, but globally. But in 2025 and in recent years, there have been so many innovations in artificial intelligence, imaging, precision medicine, advances in surgical treatment, systemic treatment, radiation treatment that are really transforming care and turning prostate cancer for some patients into a chronic disease that most men will end up just living with, like high blood pressure or high cholesterol. So throughout this talk and hopefully at the end of it, we'll be able to understand what's new, what's relevant to patients, and how patients will benefit from this. So first area is screening for prostate cancer. This is a somewhat controversial area, as some of you may know. The traditional approach to screening has utilized a combination of PSA blood test, digital rectal exam, and ultimately, in some men, prostate biopsy. And there are disadvantages to each of these components. PSA blood testing is not very invasive. It's relatively cheap, but it's actually not an excellent screening test, which may be surprising to hear. But it's the best one that we have, and that's why it's used so often. We're actively looking for ways to improve the accuracy of PSA, which I'll touch upon in a moment. Rectal exam is something else that has been historically used to diagnose prostate cancer, although these days some urologists don't even do rectal exams anymore. It's optional as part of the screening and diagnostic pathway. It's very variable. Right? The results are very dependent not only on patient factors, but also on physician factors. So depending on patient body habitus, depending on how long fingers are for the physician, the rectal exam may not be very useful. And then with prostate biopsy, we all know the problems with that. It's invasive, it's painful, it carries costs, risks, and complications. So the paradigm now is to try and utilize invasive testing only when necessary. In the past, especially when PSA first came out, everybody would get a biopsy. But that resulted in a lot of significant issues: overdiagnosis, overtreatment of prostate cancers that were not deadly. Obviously, there's significant financial, physical, even psychological costs associated with the screening process. So the shift today is from going from just PSA only to a multimodal approach that is individualized, that is based on a given patient and that patient's characteristics. So it's not a one-size-fit-all approach. Our aim is to try and find the men that have potentially aggressive, i.e. clinically significant cancers, and ideally we don't really want to find any of the other cancers, the ones that would not cause any significant illness or death to a patient. So what we've been utilizing is a mix of novel biomarkers, genomics, artificial intelligence, and imaging. So for advancing the utility of PSA, one of the areas or one of the efforts has been to try and look at other biomarkers related to PSA that can increase the accuracy of the test. The problem with PSA, one of the big problems, is that it's nonspecific. There are many benign conditions that can lead to PSA elevation. Age, increased prostate size, infection, even normal everyday activities like riding a bike or having sex can cause your PSA to go up. And so most men with elevated PSA end up not having prostate cancer. Some do, and that's the problem. It's hard to discern ahead of time which men fall into which group. So some of the efforts have been directed at looking at variations of PSA, different iterations of PSA. These tests include the 4K score, PHI, which is the Prostate Health Index, and another test called ISO-PSA. So these tests have been shown to increase the accuracy of screening using PSA. So PSA by itself, standard PSA, probably has about a 50 to 60% accuracy in diagnosing prostate cancer. These other tests, 4K, PHI, ISO-PSA, increase that accuracy to 70 to 80%, depending on the test being used. So for example, the 4K score utilizes total PSA, free PSA, intact PSA, and another variation of the enzyme called kallikrein-2. ISO-PSA, which was actually developed here in Cleveland at the Cleveland Clinic, and is now an independent company, utilizes structural variants of PSA. So instead of looking at the total amount, we look at the shape of it. And there are some shapes that are associated with cancer. There are some shapes that are associated with benign conditions. So it's been found to be more specific for prostate cancer. And each of these tests has been used to try to reduce the number of men undergoing unnecessary biopsies. And it's been very useful in that regard. Another innovation that we're seeing hasn't seen widespread utilization just yet, but there's encouraging data out there looking at polygenic risk scoring. So what this is basically sequencing to look at not just one or two or a few high-risk genes that may be involved in prostate cancer. These tests look at hundreds, if not thousands, of genes and genetic markers in someone's genome to try and identify changes in certain genetic drivers of prostate cancer that might indicate that this certain person is at higher risk for developing cancer. So this is not used to diagnose cancer. It is used to determine what the risk, overall lifetime risk of prostate cancer is in a given patient, and it can help to tailor the screening protocol for that given patient. Should the patient start screening earlier? How often should they be screened? Should they be screened at all? Some of the studies have shown that patients in the highest percentage of the polygenic risk score could have up to a 3-fold higher risk of prostate cancer. Let me see if I can show you that right here. So in this portion of the bell curve, so to speak, these men could potentially have a 2 to 3-fold higher risk of developing cancer. Those men may benefit from more intense screening. So we've all heard about AI, artificial intelligence. It's everywhere now. It's at work, it's at school, it's in entertainment, but we're also using it in healthcare. And when applied intelligently and responsibly, I think AI has shown significant benefits and utility, certainly in prostate cancer. And this graphic here shows some of the areas where AI has proven useful, and not just in screening, but in diagnosis, helping grade prostate cancers, treatment planning, predicting treatment response, predicting the risk of recurrence. It's been useful in so many ways, and it's going to become a bigger and bigger part of what we do as urologists. The use of AI-assisted screening tools can help, again, determine which men may benefit the most from biopsies, and especially useful in what we call that gray area where PSA is slightly elevated, between 4 and 10. Other exciting developments include the use of urine. So Urine, the acquisition of urine is non-invasive, right? We all have to pee, and we make a lot of it. And in fact, the term liquid gold has been used to refer to urine because of that potential utility, especially in potentially diagnosing prostate cancer. So when I looked up that term online, liquid gold, the only thing I could find was this book on Amazon. And just goes to show you that it doesn't matter where you are in life or how much training you've gone through, you learn something new every day. So I learned something new from this that I didn't realize. I mean, I guess it makes sense, right? Urine has a lot of nitrogen in it, and there's been some precedent in using urine as a source of fertilizer for growing food. So who knew? But when it comes to prostate cancer, urine is, again, so readily available, plentiful, and so easy to obtain. And it doesn't even require a needle stick. And there are tests out there that are utilizing urine to look at cancer detection, prostate cancer, bladder cancer, looking at RNA, which are genetic sequences that can be released by cancer cells, as well as looking at methylation patterns. So methylation patterns, just very briefly, are considered epigenetic changes. So genetic changes are actual changes to the code of the DNA itself, to the sequencing, right? So if you were, an analogy would be something like if you had a word and you changed a letter in that word, that would be a genetic change. An epigenetic change would be changing the font. So instead of having a very easy font to read, it might be very close together and very dark, and you might not be able to read it as well. That's what an epigenetic change is. And there are some epigenetic changes that are associated and can drive cancer. There have been some amazing breakthroughs in imaging that have also increased our ability to more accurately screen and diagnose prostate cancer. One of the ones that I've seen in my lifetime, in my career, is the utilization of MRI. So I would say that probably within the last 15 years, MRI has become a very important part of our screening process and for performing more accurate biopsies. So ultrasound-guided prostate biopsy has been the gold standard for decades. The problem with ultrasound is that it's not very accurate in terms of determining or detecting differences in prostate architecture that are associated with cancer. Ultrasound is relatively cheap, it's fast, there's no radiation, it's harmless to the patient, but the resolution is not very good. So we found out that MRI is actually really good at detecting differences between benign and malignant areas of the prostate, and also between indolent and aggressive disease, which, as I just mentioned, we try not to find the indolent or non-aggressive disease. We want to concentrate and treat the patients that have clinically aggressive disease. So what we've been able to do is to utilize MRI and basically fuse the MRI information with real-time ultrasound guidance. So this is called fusion biopsy, and most urologists, most institutions that treat prostate cancer are utilizing this method now. So in this picture, what you're seeing is an ultrasound image that is then overlaid with MRI information, which is shown here in green, and then that red dot is basically the X marks the spot. The radiologist is identifying an area and saying, you know what, this area looks suspicious for cancer, and we then target that area to try to increase the diagnostic accuracy of the biopsy. And just to give you an idea, accuracy of an ultrasound-guided prostate biopsy standard is probably about 40%. Using MRI can increase it to 80 to 90%, depending on the modality being used. Another really exciting development that is still very new and is not yet widely adopted is the use of micro-ultrasound as an adjunct or even as a potential replacement for MRI. So MRI is very accurate, but it's expensive. And it's also time-consuming. Acquisition of one image could take minutes, as opposed to ultrasound, which is almost instantaneous. So companies have developed micro-ultrasound, which is just basically ultrasound that is performed at a much higher frequency. Standard ultrasound is about 5 to 6 hertz, and I think micro-ultrasound is about 29. And it's basically, the analogy is standard definition TV and high definition. Right? So on high definition, you can see things so much more clearly than you could on standard definition TVs. And the same thing applies here to micro ultrasound versus standard ultrasound. So on the left there, you can see the micro ultrasound image, and you can actually see an area here in the left side of the prostate that clearly looks like a mass. And this was, on this image, this patient, this was confirmed to be prostate cancer. And you can see the same image on conventional ultrasound. You can't really discern that. Right? So micro ultrasound is exciting because it combines the best of both worlds for MRI and standard ultrasound. This is something that many institutions and many providers are actually looking at as a way to support and supplement our ability to diagnose prostate cancer. We've already mentioned AI. It's actively being looked at and being utilized to enhance the ability of both MRI and ultrasound to diagnose prostate cancer. PET scanning, PSMA PET scanning is something that's come about probably in the last 10 years or so. And the PSMA stands for prostate-specific membrane antigen. So in the past, when we had patients who were at high risk for metastatic disease, meaning cancer that has spread outside of the prostate, we would often have to get multiple imaging tests to try and determine that. So that would usually include a CAT scan and a bone scan. But even with the combination of those two, the sensitivity was very low. So with PET scanning, PSMA PET scanning, this is basically prostate cancer specific scanning. It looks specifically for prostate cells. Ideally, we should only see the prostate lighting up. But if something lights up outside the prostate, that indicates metastatic disease and could have a significant impact on how we treat that patient. So being able to detect metastatic disease early can have a significant impact on how a patient does, on the prognosis. So having PSMA PET scanning has really revolutionized how we work up patients and treat them. Again, you're going to hear about AI frequently, and it's going to become more and more integrated into our diagnostic and treatment pathways. In terms of diagnosis, AI is being used to enhance pathologists' ability to diagnose cancer more quickly, more efficiently. We're using AI to help radiologists do better reads on MRI and be able to more effectively and accurately identify suspicious areas so that we can biopsy them. And then using machine learning and AI to risk stratify patients. So once somebody's been diagnosed with prostate cancer, as clinicians, we will stratify them based on their risk of metastatic disease, their risk of having aggressive disease, based on a number of clinical factors. We often will use calculators and other programs to help us, but these machines, AI, can do it much more quickly and much more accurately than we can. So let's talk about what advances there are right now in treatment and are on the horizon. So one of the things that's been very exciting is the ability to target treatment, especially for patients that have advanced or metastatic prostate cancer. So in the past, systemic therapy, even though it's been effective, can carry significant side effects, such as standard chemotherapy that I think many of us are familiar with, if not personally, through stories, seeing it on TV, reading about it. And the problem is that it's non-specific. Chemotherapy just goes everywhere in your body, and it targets all cells. It doesn't have the ability to say, oh, you're a cancer cell, so I'm going to kill you, but I'm going to leave the hair follicle alone so that you don't lose your hair. The nice thing about some of the targeted therapies we have now is that these treatments can specifically target prostate cancer cells. So going back to the PSMA PET scanning that we just talked about, that technology has been leveraged to actually use PSMA and bring treatment, in this case radiation, to prostate cancer cells and only prostate cancer cells, to try and kill only those cells and limit systemic toxicity. So radioligand treatment is something that is being looked at, and we're hoping to broaden its uses in prostate cancer. So it's very exciting. This just shows you how it works. The radioligand, which is radioactive, is bound to a molecule that is able to bind to prostate-specific membrane antigen on prostate cells. So again, it will only go to prostate cells, prostate cancer cells ideally. It gets taken up. The radiation then causes damage, physical breaks in the DNA, and then the cell dies. One of the other exciting areas of treatment for prostate cancer is focal therapy. So in the past, treatment was either don't treat, active surveillance, or treating the whole gland, meaning either taking out the entire prostate or radiating the entire prostate. And the problem with whole gland therapy is that that's associated with significant sexual and urinary side effects. And these can really, really adversely impact quality of life for patients. So one of the trends now is to try and minimize those quality of life affecting side effects by treating only the aggressive cancer or treating only the part of the prostate that has cancer, all right? Hence focal therapy. And some of the more common focal therapy modalities include HIFU, which is high intensity focused ultrasound, cryoablation, freezing the tumor, and electroporation, which is using electrical energy to kill cells. At Metro Health, we've used both cryoablation and electroporation. The electroporation technology is called NanoKnife. This is the one that I have the most experience with. And it's been very effective in properly selected patients. It's not right for everybody. That's the important thing. There are disadvantages to focal therapy because we're treating only part of the gland, so there is a higher risk of recurrence. But for properly selected patients, it can be a very good treatment option. And the reason is because it minimizes damage to adjacent structures like blood vessels and nerves. As I said, it's minimally invasive, and it can be a good option for patients that do not desire whole gland therapy, but those that are not quite so comfortable with just being watched or being surveilled. There are other ablative therapies that are in development that are coming out, laser, ultrasound, steam, and these are also showing promise in the ability to apply focal therapy. Other advances are in surgical treatment of prostate cancer. This is near and dear to my heart as a robotic urologic surgeon. The robot that is most well known is the Da Vinci system by Intuitive, but there are many other robots that are coming out now that may also prove useful in treating prostate cancer. My experience is with the Da Vinci system. So there are advances that are available now that have really helped us, that have really pushed the state of the art. For example, having tactile or haptic feedback. One of the disadvantages of the robot traditionally is that you don't have the ability to feel the tissues, the resistance. And having that feedback and being able to feel how hard a prostate is or how hard tissue is can impact how we do the surgery. And doing it open or doing it laparoscopically, you get that pushback, you get that feel. With the robot, you didn't. Now, the newest generation of robot does incorporate haptic or tactile feedback. They've incorporated AI assistance in some of these systems, and even what I call, crowdfunding or crowd surgery. So you have the ability, the system has the ability to tell you that, 75% of surgeons exert this much force when they're picking up this part of the prostate, or 80% of surgeons do it this way at this point. And you can compare yourself to other surgeons and see, well, do I want to follow the consensus or the standard of care, or is this a given situation where I may need to do something differently? One of the things about which I've been very excited is the single port robot. So you can see here that there are two robots here. The one on the left is the multi-port robot. The one on the right is the single port robot. And the main difference here is the footprint of the robot. So instead of having to place 4 ports and utilize 4 arms to do a surgery, we can actually go in through 1 port that in some cases requires only an incision that is about 1 inch in length. And it's actually pretty amazing. This is what that port looks like, and this is how the instruments articulate through that port. So it looks like something out of the Matrix. It's very, very futuristic. But the arms articulate out of that port, and basically you're able to do everything that you can with the multi-port through just that one single incision. And actually I find the single port to be much more versatile than the multi-port. It's still relatively new and hasn't been adopted as widely as the multi-port yet, but both systems are very, very useful in our ability to treat prostate cancer. This shows you one of the benefits of the single port system. So the multi-port system, because it requires placement of 4 arms, requires more real estate. So we would often have to place our ports through the abdomen. We call that the transabdominal approach. So when you go transabdominally, you run into all the other organs in the abdomen as well, including the intestines and many other vital structures. And for patients who've had prior surgery, that can sometimes be difficult. With the single port, we don't need to do that. We can actually go into what's called the pre-vesical space, or even into the bladder itself. So there are some surgeons who are doing the prostate removal through the bladder. We call that transvesical. And so that's a very cool approach with significant benefits for the patient, given the single incision, less pain, quicker recovery. Some of these patients are going home the same day. Another advance that we've been utilizing is enhanced recovery. This is just basically a protocol using preoperative optimization and education, focusing and emphasizing minimally invasive surgery, using non-narcotic pain medications, encouraging patients to get up and walk around as much as possible, getting drains out, getting catheters out, and just getting patients out of the hospital as quickly as possible. And it's been very helpful. These are some of the advances in radiation treatment. And just basically showing you that it's not just in surgery, it's not just in focal therapy, it's throughout all of the modalities that we have. Systemic medicine has also seen benefits in some of the work that's being done. Some of what's really been exciting is the trend towards precision medicine, individualizing and tailoring treatment to one given patient. Because every patient is different. As we know, cancer is a very heterogeneous disease, right? Prostate cancer is very different from breast cancer, is very different from lung cancer. But even within prostate cancer itself, each patient is different. And every person's cancer may respond to different treatments in a different way. So one of the ways that we've tried to leverage that is using genomics to try and allow precision medicine. So in the example here, we can take tumor cells from a patient and basically recreate the tumor in the lab, creating tumor organoids. So we recapitulate the in vivo, the in-body system to in vitro in the lab. And then we can use those organoids and we can test treatments on them without testing it on the patient. And determining how cells respond to certain treatments, then we can say, well, you know what, in the lab, this particular treatment was very effective at killing the cancer. Potentially we can utilize this and offer it to the patient. What are some future directions? There's some really exciting things on the horizon, and kind of related to the precision medicine that I just talked about is the concept of something called the digital twin. And utilizing not just genomic information, but monitoring from smart apps and your phone, your Apple Watch. AI can utilize all of this information and basically create a virtual or a digital twin. And we can use this digital twin to predict how someone's cancer might progress. And we can also use it to predict how somebody's cancer might respond to certain treatments. And again, being able to do all of this on your digital twin, which does not feel pain and would not suffer any consequences or complications from treatment, would be great before we would offer it to the actual patient. Right? So this is a very exciting area of research that is being actively looked at. Other areas of research and ongoing efforts include combining therapies, multimodal therapy, which is often has been used in other cancers to great effect. Biomarker-driven treatment modifications, again, utilizing an individualized, tailored approach, that not every patient is the same. One size does not fit all. Something else that you all may have heard of about in the news, and maybe some of the ethical considerations about gene editing, genetic modification. You know, we all know, some people make a very big deal about genetically modified foods. We're talking about genetically modifying people. So there's a technology called CRISPR. CRISPR stands for Clustered Regularly Interspaced Short Palindromic Repeats. I know that means nothing to you. That's why we call it CRISPR for short. So what CRISPR is, it's based off of a technology where we're able to utilize, we can introduce a system into a cell to basically cut out a gene and insert something else into that area. So we could use this, presumably, to inactivate a gene that's causing cancer, or we could reactivate a gene that helps prevent cancer. So theoretically, if we were able to identify somebody in their 20s or 30s that has a gene that will ultimately lead to cancer in their 50s or 60s, we could intervene earlier and potentially fix the genetic pathways that are defective. Right? This is still very much in the nascent phases. Obviously, there are many ethical considerations, but these are studies that are being done. Mouse models have shown promise. Again, so very exciting stuff. One of the other things that we want to focus on is health equity and being able to provide care for everyone. The issue with the care that we provide is that it's not always available to everyone. Just from a urologic standpoint, you might be surprised to find that almost 70% of counties in the United States lack urologic care, meaning that they don't have access to a urologist. And so we're not talking about a urologic oncologist, we're just talking about a urologist in general. We all like to stay in the big cities. And so rural areas and other underserved areas often don't have access to the same quality of health care that we have here in a great place like Cleveland. So we could potentially mitigate and supplement that shortfall by using AI. AI can be deployed anywhere. Portable mobile diagnostic devices can also be useful, as we talked about a while ago when we were talking about digital twins. And the other thing to keep in mind is that we want clinical trials to try to be more reflective of the populations of patients that we serve. So historically, many of the studies, the big studies that were done, were very homogeneous and often did not include any significant proportions of minority patients. And we know that diseases affect people differently. They affect different ethnicities and races differently as well. So that's something that we should consider. So the takeaway is that in 2025, the landscape of prostate cancer diagnosis and treatment is rapidly evolving. We are trending towards more personalized, individualized treatment using precision medicine, using a combination of genetics, artificial intelligence, and the latest treatment techniques to accomplish that. And the ultimate goal is to basically render prostate cancer, which is one of the most common cancers that we deal with, unfortunately, into a chronic disease that hopefully all men will end up living with and not die from. And I think we're heading in that direction. So I'm very optimistic about the future for prostate cancer diagnosis and treatment.